Good morning, everyone. Welcome. Thank you all for joining us on this hot, steamy, could be a hurricane, could be a tornado, could be any kind of weather day. It's always good to see you. I miss seeing people in person. And I was thinking we were a long way towards getting back to that, but now it seems there might be a little rethought about all of that. I want to begin today, as always, by looking at our numbers, and you'll see Nora has some slides. And you will see the first half of 2021 in Middlesex. And I want to just point out one thing that I think is interesting for a couple of reasons. And for those of you who've been with us for a while, you'll recognize that. You will, excuse me, at this point, we have had in Middlesex 133 non-suicide overdoses that we have responded to. That is an uptick from both of the preceding years. But what is interesting is, and this is consistent across the state, the beginning of the year, deep of winter, excuse me, COVID having continued. You'll see January and February are both pretty high. In March, we start going back to not a good number, obviously, but a more consistent number. And then we began in April that downward trend, which we'd like to see. Our numbers in July, and it's consistent also with 2019, which if you remember was pretty similar weather-wise. We always see a very dramatic increase when we have hot, humid weather. And I'm sure for those of you outside, you're seeing that as well. One issue seems to be around dehydration and whether that in some ways affects people more. I think it is an important community issue, and we've talked about this before and done this before, and Lowell has done this for a couple of years since we noticed that connection. The importance of getting water on the street, getting bottled water out on the street for people, that does seem to make a difference in that hot, steamy, like today, kind of weather. Margaret Hester, who's with us today, just made another interesting point, which is, do people hole up in an air-conditioned spot if they can find one when it's as unbearable as it was last week, I guess, and maybe used by themselves. So I think it's just interesting that we seem to have pulled ourselves, and in part, I'm sure, because people were a little more optimistic about the pandemic. I think by March, people were starting to feel like, okay, I can get a shot, things are going better after that kind of dark months of January and February. And then our numbers go back, they're much more consistent with the prior 2 years. And then we have that jump, which is similar to 2019, which if you remember was also a pretty steamy summer. So that's just an interesting piece, and it's also something to think about in terms of our community work. The other piece is, you recall we heard last month from Deirdre Calvert about the significant racial disparity in the impact. And you can see, I'm sorry, Noe, we can do the community. You can see the communities as we've broken those down. Not surprising, the places where our numbers have always been high, Cambridge, Lowell, they continue to be high. But it also gives you a picture of the fact that really there are very few of our communities who have not been touched by all of this. And remember, this is deaths that take place in that town. So somebody from that town who goes to Boston and has a fatal overdose is not going to show up. And conversely, if somebody from Lowell goes to Dracut, they are going to show up in Dracut rather than in Lowell. But to just go back to the piece we talked about of the difference, we saw from that DPH data that opioid overdose death rates, quote, increased significantly for Black non-Hispanic males between 2019 and 2020, decreasing for white non-Hispanic males. And again, another place where I am never happy to see women doing well, the overdose rate for women rose again in 2020, and that increase similarly was higher for Hispanic and Black non-Hispanic women than for white non-Hispanic women. So there's really no doubt at this point that disparity exists, and it's pretty substantive. The acting commissioner of the Department of Public Health has announced that the Bureau of Substance Addiction Services will be investing $40 million over the next 4 years, averaging out to $10 million a year, specifically for expanding access and enhancing services for Black, Indigenous, and people of color communities. And you'll see it's particularly important as we look at it, and Nora had that last slide, and those overdose deaths we've had this year, where we know the substance. A couple of interesting things. Obviously, heroin unfortunately remains way up there, and that is usually because it's being used to have something else on board, most often the fentanyl. 14 fentanyl deaths that we are able to confirm is a substantial number. And the increase, although we're only at 4, for the many, many years, we were at 0 on cocaine, and we know obviously that's being used to be cut with the fentanyl as well. Pills have made a pretty dramatic comeback. 8 of our deaths, non-suicide deaths, were by pills, which is higher than we had been seeing. So just some sort of backdrop of that work. And today I'm really happy that we're going to be hearing from 2 sets of partners in this effort. First, we're going to hear, as I mentioned, from Margaret Hester. And many of you know Margaret. She's been at these meetings with us in a variety of roles. She earlier was working with Jim Cormier on the mass high-intensity drug trafficking effort. And she is now the lead at Boston Medical Center on the Healing Community Study. Margaret will be joined by one of her partners, Lauren Kingsling, who works with the Healing Community Partnership, specifically in the Lowell area. And Margaret is a part of that team, but she does a lot of work imagining and leading this effort. So we're happy to welcome both Margaret and Lauren this morning.
Great, thank you so much, DA Ryan. We're super, super honored to be here. I feel like we've been planning this between ourselves for quite a while. So thank you all for listening to us this morning, especially shout out to our coalition members. I see a lot of representation here today. I know we just had a coalition meeting yesterday, so it's great to see all of you again in a very short time span. So I'm gonna go ahead and share our slides. We'll start with brief introductions, an outline of what we're covering today, and then I will pass it over to Margaret to do a general overview of the study, and then I'll be taking it from there to talk about our specific efforts with the Lowell Coalition. I'm just gonna throw this in presentation mode. Hopefully everyone can see it all right. All right, perfect. So I'll start with myself. So my name is Lauren Kiesling. I am the community engagement facilitator for the Lowell Coalition through the Healing Community Study. I'm employed directly out of Boston Medical Center, which is the holder of this grant when it came down from NIH and NIDA. So BMC, all of us who really work internally on the study are employed by BMC, along with some other community partners that are brought in for our various fiscal agents for each of our Wave 1 communities. So that's me. I've been in this meeting a few times in various roles throughout the city of Lowell. So when I came into this role, I was super, super grateful to be given the opportunity to be assigned Lowell, to come back in and participate in this awesome work with all of you again. And I'll pass it over to Margaret to introduce herself as well.
Hi, everyone. To familiar faces, hello, it's good to see you again. And for those who don't know me, my name is Margaret Hester. I work as a criminal justice specialist for the Healing Community Study. And while that title makes me sound like a supporting character on Law & Order SVU, what it means is that I support implementing interventions that are for public health for substance use in criminal justice settings. And I'm very pleased to announce that I just got a promotion from DA Ryan to now be the principal investigator of the study. So Dr. Jeffrey Samet, step aside, Margaret Hester is leading the way.
I have that power. It's like Rita making people the Pope. Rita sometimes just elevates people to Pope.
Exactly. My potential is endless, according to DA Ryan, which I appreciate. But in all honesty, it truly is a team effort. And I'm so glad to be presenting this with Lauren today.
Great. Thank you, Margaret. So can folks see this okay? I have a window like that I'm seeing in front of me. Is it blocked or can you all see this okay?
So I'm seeing a sign that says, please move window, but now it's slowly fading into the
background. Dramatically moving around. All right, great. We're good. All right, thank you. So again, Margaret will be leading us through an introduction to the Healing Community Study, after which I will be jumping in to provide a highlight of the Lowell Coalition and summarize the chosen interventions that have come out of all the very hard work that the coalition has put in for almost 2 years that the study's been in Lowell. And then we'll be wrapping up with a brief snapshot of the intervention reach for the last 7 months, We do have some hard numbers to show all of you about each of our interventions and how many folks they're seeing, specifically folks with OUD who are coming through their door to help us reach our goal of reducing overdose death by 40%. So I will go ahead and pass it over to Margaret. And I will also try to get this window to move away as we do so, but Margaret, please take it away.
Thanks, Lauren. So for those of you who may not be familiar with this study, it's called the Healing Community Study. And in this instance, HEAL stands for Helping to End Addiction Long-Term. And I think that, like, again, while I just got this promotion from DA Ryan, I wasn't in that position before when we were naming the study. And ultimately, it's not just about helping to end addiction long-term, because we recognize that many people will not be in a place where they want to stop their drug use. So in all honesty, the study should probably be called Keeping People Alive Long-Term, because people where they're at in a variety of different terms. But again, not my circus quite yet. So it's the Healing Community Study, Helping to End Addiction Long-Term. And what's the goal of this study? The study's goal is to reduce overdose deaths by 40% across all of the study communities involved in this study. And this is going to be done through a collaboration between community partners and researchers at Boston Medical Center. So who are these communities that are trying to reach this 40% goal? The study is funded across 4 states, Kentucky, Massachusetts, New York, and Ohio. And in total, this is 67 communities with a mix of rural and urban. And these communities, for the purposes of the study, are going to be split across 2 waves. Right now, we're in wave 1.
Sorry, Margaret, I'm a bit frozen over here, but I will.
It's okay. I can either go off the cuff or we can have a sort of dramatic pause, let the suspense build.
We're good. I like a dramatic pause, but
yeah. And so while it's good to know that this study is operating in so many different states, I'm sure the majority of the people on this call are wondering, okay, how does this apply to Massachusetts? And in the case of Massachusetts, we have 16 communities that are selected. For wave 1, we have 8 communities and a second 8 for wave 2. It's also important to note that while we use the term community, the rural communities are often put in clusters. And for wave 1, those clustered rural communities are Shirley and Townsend and Bourne and Sandwich. Those are considered one community for the purposes of the study. Again, not how people really operate, but studies are funny things, and that's kind of how we divided it up. The remaining communities are Lowell, which brings us here today, Brockton, Holyoke, Salem, Gloucester, and Plymouth.
Sorry, I wasn't aware of this feature, but like here they.
You know, Lauren, I wasn't either, and I made the presentation. So I'm just full of surprises today. So if you're wondering how we're going to reach this 40%, we're going to use something that we call the Communities That Heal intervention. And this intervention is designed to reduce opioid-related overdose by, again, getting these different partners together across healthcare, behavioral health, criminal justice, and other community partners to focus on 3 main areas that we often refer to as the 3 main buckets. So these areas are increasing naloxone distribution and overdose prevention education, increasing access to medications for opioid use disorder. The study calls those MOUD. They're also often referred to as medication-assisted treatment, or MAT. We prefer the language MOUD because the medication is the treatment. It's not assisting anything else. You know, it's not a secondary character, it's the main character. And we're also improving opioid prescribing safety. So what does this intervention look like? The Communities That Heal intervention starts by co-creating solutions with researchers and coalitions in the study communities. This is done through a community engaged approach and with also this health communications aspect involved as well, with the aim to increase demand for evidence-based practices, also known as EBPs, and reduce stigma. So after that phase within the coalition, it goes on to adopting the evidence-based practices that were identified and created by the community partners, focusing again on those 3 main buckets of increasing naloxone education, or naloxone and distribution and overdose education, increasing access to medications for opioid use disorder, and increasing safer prescribing. And then the last stage is the outcome, is seeing how these reduce deaths in the community through these different community engaged interventions. Now I'll pass it off to Lauren.
Thank you so much, Margaret. I do want to pause really briefly to answer any questions or comments about the study process. I know we went through that pretty quickly, but are there any questions about the study design itself? We're happy to take a stab at answer. All right, and if anything comes to folks' minds, we can absolutely address them at the end of the presentation. So as Margaret said, Lowell is one of the 8 Wave 1 communities, and we have officially been in Lowell from the BMC and the Healing Community Studies standpoint from January of 2020. So the very first Lowell Coalition meeting convened in January of 2020. I honestly cannot believe it's been so long, especially, we had a few meetings under our belt before COVID hit. So it's definitely interesting to think back about all the adjustments we've all had to make during that time. So again, initial meeting was in January. Over time, pretty much the next 3 months or so from that point, the coalition expanded out to emphasize membership from multiple treatment organizations across the city of Lowell and outside of the city, ranging from primarily substance use disorder treatment, but also ranging to behavioral health treatment and peer support services. I mention this because when the study first came in, and this is before I was on board as well, we had our very first phase 0 meeting at the mayor's opioid task force meeting. And since then have kind of ballooned out to try to convene as many stakeholders as possible from the various coalitions within Lowell. I will say we were at a very large advantage in the city of Lowell because there was so much coalition infrastructure. It made it very, very easy to know who to contact. It's not necessarily been the same experience in our other Wave 1 communities as they've been starting from the ground up. Again, there was some infrastructure, but again, not as strong as Lowell. So we feel very, very grateful, one, for everyone's willingness to engage with the study as another grant, another meeting to attend, all of that good stuff. We're just extremely grateful for everyone's buy-in and for the existing infrastructure in the city. So from here, across the next several months, the coalition underwent, as Margaret had mentioned, an extensive data-driven decision-making process to produce, at the end of the day, an action plan addressing the main EBP categories outlined by the study. So we were able to walk away by basically August of 2020, so a year ago now, with a very concrete plan for how to expand naloxone education and distribution within the city, how to expand access and improve linkages to medications for opioid use disorder, specifically buprenorphine and methadone, as well as promote our safer prescribing training opportunities. As I move forward, I'll talk about each of those interventions, but just wanted to once again reflect on all of the hard work that went into that. The study does operate on a very tight timeline for a very lofty goal. So again, just wanted to note that pretty much over 8 months, the Lowell Coalition was able to reach their goal of having an action plan and was able to actually act on that plan in a very small amount of time during a pandemic, no less. So from that point, each intended implementing organization was tasked with standing up the interventions that the coalition had decided on, working with them and working towards expanding existing services with strong support from both the coalition and BMC. And as of July of 2021, so last month, all of the Lowell Coalition's intended interventions are up and running, which is just in time for the measurement year, which I will explain very briefly. So I won't go into the Wave 2 portion of this timeline, but really want to focus in on the Wave 1. So as we were saying, there was a lot of study startup on the BMC side from April of 2019 through December. We first to Lowell in January of 2020, and now we are all the way up to August of 2021. As you can see, if you look down to this red square here, is a comparison communities that heal versus usual care. So that really means that the CTH process versus what was the status quo before the study came in, using that as the metric to determine whether or not the interventions are effective in helping reach the 40% reduction goal. There was an extension, a 6-month extension put on the study kind of right around March of this year. So it did push our measurement year up to July. So that's what I mean when I say that, oh, we have all of our interventions up and running by July 1 of this year. And now we're going to be seeing the impacts of that measuring through June of 2022, where the study will leave Lowell and then move to the Wave 2 communities. Are there any questions about this timeline? Hopefully I was able to make that concrete. Sometimes it gets jumbled in my head as well. All right, moving forward. So we'll start with the OEMD, which once again stands for Overdose Education, Naloxone Distribution Interventions that the Lowell Coalition came to consensus on and have since hit the ground running with. The first of which is our first responder leave behind, which is headed up by Trinity EMS. I know that John Kelly has had many a platform in this space, so you all know what amazing data collection they do and amazing work that they do specifically for folks in our area using opioids. So we were able to partner very closely with Trinity to provide them with a line item from the study budget to give them a couple hundred naloxone kits to carry on their vehicles, not to actually use, because they already have the naloxone on their vehicles to be able to revive people themselves, but to leave behind. This is a model that has been used in multiple states of the country. We do have a close partner in New Hampshire who's been doing this for quite a while, in other areas around Massachusetts. But essentially, if Trinity responds to an opioid related incident and that person either refuses transport or doesn't want to be transported or doesn't need to be, say if it's a mental health crisis or something along those lines, if those folks are interested, the EMTs on the truck can leave naloxone kits behind right there. So instead of giving somebody, hey, like you can go to this OEMD site or here's a phone number to call, they can get that kit right then and there. And again, I'll talk about how many kits they left behind so far, but there's been really great buy-in from the Trinity EMS staff, as well as from the community. So it's just another avenue for folks to be able to access naloxone. The second intervention is hiring our harm reduction navigator. He's actually on the call with us, Derek Sampson. This is an intervention that launched just last month, and it's still categorized in OEMD because we initially wanted to allocate funds to have a sole naloxone outreach individual who was both bilingual in English and Spanish to reach our Spanish speaking population. But the coalition decided a little bit down the line that they'd rather collapse this position into two. So not only is Derek able to do naloxone trainings and reach that target population, but also, educate folks on medications for opioid use disorder and provide and connect people to other recovery services as well. Our last OEMD intervention is incentivizing our OEMD coordinator, who is Gianna Sandelli, also on this call. I'm sure most of you are very near and dear with Gianna and know all the great work she's done. She has been tasked with helping provide a more unified approach to OEMD services in the city. There are currently 4 different naloxone distribution sites in the city funded by DPH, and Gianna has been spearheading trying to unite those forces so that they aren't duplicating services and so that folks have, again, multiple pathways to naloxone, and ensuring that there's clear communication between all of those sites. So some of the data highlights from these interventions. So as I had mentioned with the first responder leave behind, as of last month, Trinity has left behind 84 naloxone kits, which again, reminder that there are 2 4 milligram doses of naloxone in each kit. How we've been tracking it is we pretty much look at the overall ORI numbers for the month and say, okay, how many of that, how many of those were naloxone left behind with if that person was not transported. So thus far, there is now 84 more kits of naloxone out in the community through this intervention. And there have been 35 OEMD trainings that have been provided to various community organizations through Gianna through Lowell Co-op. So this is actually separate from the study, but wanted to give a mention to the amazing work that Gianna and the co-op have been doing to try to, again, expand folks' access and comfortability with naloxone, and that there have been, again, 35 trainings thus far. I will pause one more time. I'm a big fan of pauses, so I apologize, and see if there are any questions or comments about the OEMD interventions. All right, we can go ahead and move on to our medication for opioid use disorder interventions. So this is really where the crux of most of the funding for Lowell has gone into, as it's related to HCS, and also where we're going to be seeing, quote unquote, the most impact because of these specific clinical interventions. The first of which is when the study came in, the Circle Health or the Lowell General Hospital Bridge Clinic did already exist. There's probably been presentations about it in this space actually over the last several years. The Bridge Clinic did exist and their funding was going to be running out right when MassHeal came into play. So we were able to pick them up and support that staff, paying for the salaries of that staff to keep that program going, in addition to providing another NP on staff, as well as 2 other recovery coaches. So we've been able to, bolster and take the amazing infrastructure that already existed with the Lowell General Bridge Clinic and just turn it into the absolute powerhouse that it is today. I'm very, very excited to show you their numbers They've been seeing a massive uptick in the amount of people who are coming through their door, whether to be connected to services, just have that touch point with the hospital, that healthy touch point, or to be connected to MIUD and get started on treatment if they're interested. The second here, which is related, is the creation of the Lowell General Hospital Inpatient Addiction Consult Service. This is something that did not previously exist before the study came in. And this is, as of right now, a one-woman show. When I had mentioned that part of the Bridge Clinic funding went towards hiring an additional NP. The NP, Lisa Brown, has been completely running this show, and we are so impressed with what she's been able to do. This differs from the Bridge Clinic, whereas folks are not necessarily walking in to be connected to services, but they're already inpatient at the hospital. So if someone, say, presents in the mother-baby unit at Lowell General, and they have a history of opioid use disorder, or are just interested in talking a little bit more about their options related to substances, Lisa can be pinged by the physician who's with that individual and can do a consult with that person. So this is, right, the Bridge Clinic is outlining the outpatient approach, having the patients come to them, and then the inpatient consult service is illustrating when patients are already in the hospital, how can we help them out, provide them services, and again, and link them to MIUD care if they're interested. I'll kind of pair these together. The next intervention, again, is the harm reduction navigator, Derek, that I had mentioned previously, as well as the other member of their outreach team, Jennifer, who is an outreach registered nurse. So this intervention, again, had started where we were going to have the OEMD individual and then 2 individuals on this MUD team. But again, we had collapsed it into this one harm reduction navigator position. So Jen and Derek have been out on the street doing their work for about a month now, maybe even less. Again, the timeline gets messed up in my head, but they are just doing outreach, again, have that bilingual capacity. And then also Jen is introducing the importance of street medicine. She's able to go out and do wound care, look at abscesses, refer people to the ER or patient walking centers if necessary. So this is kind of a first approach to this boots on the ground intervention that we hope we'll be able to develop throughout the year, throughout the years to come. And after the study is gone, maybe even, bring in a mobile unit, other creative ideas that the city would like to buy into. But I did want to give a brief platform to Jen or Derek to talk a little bit about their work, what they've been seeing, introduce themselves to the group, and just talk a little bit about the importance of, having wound care available on the street. So I'll go ahead and pass it off to Jen or Derek if you just want to give us a few examples of what you've been seeing out there.
Thank you, Lori. Is that better? Thank you. Sorry about that. Thank you, Lauren. I'm Jen. I'm an RN outreach nurse. I started working with Derek a little less than 4 weeks ago. Wasn't quite sure what we're coming into, but it's incredible. There's no need to really plan the day. Once I go out and start doing wound care on someone, the need is immediately apparent. People just start flocking to us, and I'm really grateful to have Derek, as I'm not bilingual, he's bilingual, and also great with the crowd control. Many people that we see do not want to go to ERs, and they don't want to go to urgent care. So I'm trying to reach people before an infection sets in so we can avoid that, while doing harm reduction discussions, while discussing hopefully treatments down the road for them, distributing Narcan. But the wounds are incredible on the streets, and people, once someone sees what I'm doing, more and more just come to us. And I didn't know there was I'm from Cape Cod, so coming here, I just moved to the area, but there's such a need, and it's been incredible. Derek's been an incredible partner, and I'm really grateful to be here with everyone and really reaching people where they're at, where they normally wouldn't go seek care, and hopefully helping them before the infections are really, they either lose a limb or they need further treatment that they refuse to go get until it's very late. So thank you. It's a lot. We're learning as we go, but it's been quite the month. So thank you.
Yeah, absolutely. Thank you so much, Jen, for sharing. Just wanted to give, again, this team a platform. I think you'll all be seeing them quite a bit more, either in both virtual spaces and out in the streets of the city. So definitely, connect with them. We do have contact information at the end. But thank you so much to both of you for the work that you're doing. Again, as we've said before, we are so incredibly excited that you're on board. And lastly, our last MAUD intervention is Wheels of Hope, which is run by both the Massachusetts Substance Use Helpline and Health Resources in Action. Wheels of Hope is a transportation service that was piloted well before the study had come on board, initially kicked off by the Merrimack Valley Project and had been picked up by the helpline during that time. So essentially how this service works is that folks can call the helpline, say, hey, I'm in the Merrimack Valley area and need a ride to either inpatient treatment or outpatient MAUD treatment to get to an appointment, and or harm reduction services as well. I should mention, if someone does need clean syringes or Narcan, they can also utilize this service to be transported to those services as well. They can call the helpline, say that they're a Merrimack Valley resident, and then be connected right to Lucos Transportation, which is a local taxi company who is contracted with the helpline, set up all of the logistics of the ride again, and be sent on their way. And they are round trip visits as well, so they can be brought to and from. I will say that there is a 7-ride limit. So say if someone had just been initiated on MAUD, is going to their methadone appointments or going to their Suboxone intake appointments, they do have a 7-ride limit. But there are services both within Wheels of Hope and at those providers that help find a more sustainable transportation solution for those individuals. So we are just one branch of the funding that currently helps fund Wheels of Hope. Again, their reach is all of Merrimack Valley, and you can find all of the towns and cities that are included in their catchment area on their website, also at the end of this presentation. But what the Healing Community Study, our budget item for them is specifically Lowell residents. So when I show our data coming up soon, it is specifically for Lowell residents who have received rides since January of 2021. So just a few highlights here. So going back to the Lowell General Bridge Clinic, since January of 2021, they have seen 387 total individuals with opioid use disorder. There is some overlap here because people do come in for repeated visits, but overall a huge uptick in the amount of individuals with OUD being seen at the Bridge Clinic. I did not include individuals with alcohol use disorder because it's outside of the study scope in here, but they are seeing also a large amount of individuals strictly with alcohol use disorder as well. So also just want to, their workload is quite a bit because they're seeing quite a lot of individuals. Secondly, here, there has been 161 opioid use disorder consults completed through the inpatient addiction consult service. Again, this one woman show with Lisa Brown, she also does see pretty much an equal amount of individuals with alcohol use disorder. So she, again, is providing that very much needed in-reach and word is spreading across both hospital campuses to get consults if someone does present with OUD or AUD. And lastly, since January, there have been 120 rides provided to Lowell residents through the Wheels of Hope program. So again, if you are in this area and you have individuals who are looking for inpatient treatment or to get started on MUD and just don't have a ride to get started, I highly, highly recommend that you reach out to Wheels of Hope to at least have a solution for right now. I'll pause once more and see if there are questions or comments about any of our MUD interventions or the data itself. All right.
Lauren, this is Nora.
Yes, please.
So the uptick in folks seen at the Bridge Clinic, is there any sense of, is that happening because there had been a decline in staffing and you were able to support additional staffing, or do you have any sense of why that has happened?
Yeah, I can absolutely give an abbreviated version. Again, any other members of the Lowell team, please feel free to chime in as well. I think it's a perfect combination of both. So we were able to, again, augment their staff with at least one other additional recovery coach, specifically a recovery coach who is in the emergency department, who's able to physically walk people over to the Bridge Clinic if they are presenting with substance use disorder or post-overdose or interested in MAUD. So yes, I think it is staffing. It's also just having connecting the Bridge Clinic with BMC and other clinical entities who have done this work previously. There are a lot of training and technical assistance opportunities available. For example, the Bridge Clinic staff meets with BMC staff as well as all the other Wave 1 communities who have stood up a Bridge Clinic. They all meet once a month, or actually every other week rather, and talk through cases, talk through how to optimize their services, and have that support. So again, I think it is that perfect pairing of, having the funding to sustain the program itself, adding additional staff, and then also that training and technical assistance from BMC has helped tremendously.
Lauren.
I would also just add that the success of the Bridge Clinic wouldn't be possible if there hadn't been community level efforts to make MOUD treatment less stigmatized for members of the community. So their ability to appeal to and accommodate walk-ins has been a huge shift in their volume. It's also a testament to the work that many people on this call have been doing to make sure people know that care is available to them when they are ready to seek it. And that's been ongoing work in the community for years that I know a lot of folks on this call have been working on. So I hope that this is also seen as a testament to the work that you all have been doing to make sure people feel like they deserve and have safe access to care.
Thank
Hello,
you,
Lauren.
Roy. Sorry, go ahead.
Hi, Lauren. Roy Frost from Bill Riga. Thank you for your presentation. Just did I understand you correctly when you put this last slide up that 387 total individuals with opioid use disorders that went through the Bridge Clinic are specifically Lowell residents, or is this for Middlesex County?
This is for anyone who comes through their door. We do have an assumption that most folks would be from Lowell, but we don't actually track where those individuals are coming from at this time.
Yeah.
All right. All right, we'll keep moving through. I just have a few more slides for you all. And thank you for your questions. And our last bucket, again, the safer prescribing bucket, I will say the Lowell Coalition, we did not allocate specific budget items toward this, but the study did come pre-packaged with 2 opportunities that we've been promoting pretty much for this specific bucket. So one of which is promotion of the scope of pain trainings. So basically scope of pain is, a training available both in webinar and in person when appropriate for prescribers, various providers, nursing staff, pharmacists, and first responders, just about how to, approach individuals with SUD, and most of which who have co-occurring chronic pain, and how to prescribe around that, right? Because we want to make sure that even if folks do have a substance use disorder, but do have chronic pain, that they're able to have access to medications to give them relief as well. So that's really the main focus of scope of pain, is how, when you have that tricky situation, how do you appropriately prescribe while also giving dignity back to the patient? So thus far, we've had 13 total attendees attend one of these trainings from Lowell specifically. And if you are interested in attending a training, there is scopeofpain.org, but we also do have a monthly newsletter that comes through HCS. I will drop the contact information for Devin Goldberg, our community coordinator, who also curates the newsletter each month. I'll drop that at the end of the presentation. If you're interested in being on that, not only can you receive updates on each of our interventions, but also, again, upcoming opportunities for scope of pain. And the second service here is the mixed app call-in service. So if you are a prescriber and have questions about prescribing for chronic pain and or substance use disorder, kind of same theme here, you can call this number and you'll be connected right to a prescriber themselves who can help walk you through some of the potential dosages, any other questions you may have. You can also go to mixedapp.com. But again, this is also reflected in our newsletter. So to wrap up, the interventions are picked, but you're interested in joining us on the study or just interested in the work, what comes next? So while the funding has been allocated at this point, we do offer learning opportunities, training and technical assistance to our community partners. Some examples of trainings that have happened in Lowell and mostly within our other 8 Wave 1 communities are Harm Reduction 101 and Myth Busting, Naloxone Leave Behind program best practices. John Kelly was actually at this one and was able to share out the amazing work that Trinity's been doing to other organizations around the state. Outreach collaboration, more information on medications for opioid use disorder, and then COVID-19 and overdose response is just a very small sample of what can be offered through BMC in collaboration with our other Lowell partners to help elevate the work that they're doing and learn best practices from one another, as well as other organizations across the state. Again, I'll pitch the newsletter one more time. All of these will be available in that format, but we also are very, very closely tied with the Greater Lowell Health Alliance. They are the fiscal agent for this project. And Hannah Tello and Devin Goldberg both work on the study and on GLHA, so it'll also be pushed out through those networks. But this is just some of the work that you can get involved in now. And we are also always looking for new coalition members. Basically every month, we're looking at each monitoring report, troubleshooting any issues that we see, just building relationships to help, really optimize this continuum of care to get people, where they need to be and where they want to be with as much dignity as possible. So please, if you're interested in that work, feel free to shoot me an email or anyone else on our staff to get involved. I can send this out to Nora afterwards, so you all have it, but I just wanted to highlight the contact information for a few of our interventions. We have contact information here for the Bridge Clinic, Wheels of Hope, and for Lowell House, and also how to reach Derek and Jen if you're interested in hearing more about their work or, helping them learn the city a bit more and about your organization itself. So I will send this out. So as I move forward, you won't miss anything. And then finally, here are our contacts. So both Margaret's email and mine are here. And then there is also a link to our Massachusetts study page if you want to learn more about the study itself. But again, please feel free to join the coalition if you'd like. There's a lot of great stuff to see in the last year of the study, and we're really, really excited to see where this can take us. Thank you all for your time. Thank you so much for this platform. We are, again, super, super grateful to be in Lowell with such amazing partners all around us. And again, coming in with such a strong infrastructure has really made all the difference. So we are, extremely honored to be able to be in this space. So thank you so much. We appreciate it.
Thank you, Margaret and Lauren. People have last questions, thoughts?
Dave Hunt, just want to make a quick comment for people on the call that don't realize DA Ryan offered this training about 2 years ago over Lawrence Memorial, and it was extremely enlightening, different options for the scope of pain that are available for everybody. Instead of just thinking push the drug, push the opioid, I'm a first responder, and it just gave so many more options to open my eyes up. I do see several people on the Zoom call that were actually at that training, and for the people that have not considered it, it takes about an hour, 2 hours. It's really something that'll open up your eyes to other alternatives.
Thank you, David. And, I would just call your attention to an article that I think is in your materials for today, or Nora's put in the chat. Really a concerning spike in the number of prescriptions, opioid prescriptions being written again for younger people. How long the prescriptions are, how much they're getting. And we at the Scope of Pain talked a lot about being good consumers for your kids in terms of, is this my only option? How many of these am I taking home? What happens if I took home 60 and he or she only took one? What did I do with the other 59? So I think, we've been so busy with COVID and vaccines and so many other things going on. And I think, frankly, some people have either by necessity or by choice put off some other medical care that may have required them to continue with pain medication because they didn't get their ACL fixed, or they didn't get their wisdom teeth out, or something else because they were afraid, or because they were rescheduling. I'm concerned that that number is sliding up again. And we know that not only has younger people starting using, but it also puts them in people's houses and gives people who might be in a house doing work or dropping by for a house on the market access to more scripts, more pills. So I think we need to, as we kind of move back to thinking about other pieces of healthcare, just keep remembering that. Anything else? Any other questions? All right, great, thank you. Our next presenter today is Kara Cassie from Advocates, and many of you have heard the really moving and important stories that Advocates have told us about the challenges of providing care, similar to some of the things you just heard from Margaret and Lauren, providing that care in the time of COVID. And we asked Kara to come today to put a face on some of these challenges. And we know that some of you are seeing that, but we know that it's important that everybody be thinking about the scarcity of clinical staff, the challenges to access, the anxiety that's been generated just by COVID itself, as well as the economic stresses. Remember September 4th, unemployment benefits are going to end for people. That extra amount of money they've been getting from the federal government, that's another economic problem, and how it's impacting us. One of the probably, I think, most concerning things I heard recently is that our concern with people who may be dual diagnosed or who are struggling with mental health issues as well has been ongoing for a long time. I am particularly concerned about adolescents with mental health issues and their ability to access services. I had the opportunity to be at a meeting last week looking at the number of beds and things across the state. And the most concerning part of that meeting was, despite the fact that Massachusetts is going to attempt to add 500 mental health beds, many of which will be focused as an availability for adolescents, that ability to do that, which is now in jeopardy, as well as the other beds that funding exists for, is due to the lack of staff. So we have places that right now could be providing a bed that would house somebody with a mental health issue, particularly an adolescent, who, as we've seen, we have one adolescent that we've been dealing with who spent 51 hours in the corridor at the ER on a gurney. If you've got, that's not good for anybody. It's especially not good if you've got a mental health issue. We have another young woman who has spent 90 days boarding in the hospital with no mental health services being provided because she can't get into a bed in a mental health facility. And we can put the money out there to create the beds, which the Commonwealth is doing, but we can't open the bed if we don't have staff, clinicians, nurses, everybody else that we need to do those services. And we do not have that. And as all of us know, and certainly some people who are in the field here, I can have $1 million today, but that doesn't create somebody who has the education and training to take on that job. So that's a longer term issue. And a related concern, and you may have seen, we've been taking a pretty strong position on this, is, and it has been the case for a while, but it's clearly been exacerbated by COVID. We have had a number of healthcare workers in the hospital who've been suffering some violent injury. We had one of those incidents at Lowell General Hospital. We've had another at Newton Wellesley. And, you know, if we are trying to get people into a field, people going to work in that field and suffering a dramatic injury is not a way to get them to do that. So there are lots of challenges around that, but I am really very worried about this fact that we just don't have enough workers to open up those beds, because it affects every bit of the work we're doing, whether it's the police officers on the street who are responding more and more to mental health calls, whether it is the people who are dual diagnosed with substance issues as well as mental health. We're all struggling with that. And if there's no place to go for people to get treatment, we're not going to see the situation improve dramatically. So that's kind of the backdrop of that, and the backdrop of what we hear when we're thinking about the services that advocates provide. And Kara, for those of you who don't know her, works the second shift at the Marlborough Police Department. She is a co-responder in the jail diversion clinician. She's been in this job since April of 2020, ironically, the very start of the pandemic. So we're really happy to have her here with us this morning to talk a little bit about the personal side of these issues that we're seeing. So thank you, Kara.
Thank you for that introduction. I hope you guys can hear me okay. We have a really bad storm here. I don't know where everybody else is, but I just got the alert on my phone. So if you're having trouble hearing me, just someone let me know. But I am the jail diversion clinician here at the Marlborough Police Department. I'm employed by advocates. And just to give a little overview about what the jail diversion program is, we first started this program in 2003. It was founded by Dr. Sarah Abbott and Chief Craig Davis at the Framingham Police Department. That was our first program. It was very successful, and it was replicated here in 2008 in Marlborough as the second program, and then continued on to Watertown, and then we started some regional programs. Now we have 15 communities that we serve, 9 programs, because some of those are the regional programs. And our newest program is actually in Lowell. So it was great hearing the presentation before this, because your services are so valuable and will be overlapping a little bit with our clinician and Lowell. So the role of the jail diversion clinician is to be fully embedded in the police department. We ride along to all calls for service. They're not necessarily obvious mental health or substance abuse calls in the beginning. So we will ride along for domestic violence calls, car accidents, elder services, really anything. And we're on site as a tool for de-escalation, risk assessment, psychiatric evaluation, referrals, all of those things. The department that I work at here in Marlboro is really well versed in what we do, and we're really grateful for that. So they often, if myself or the other clinician is not in, they will alert us to any calls they may have been to in our absence that may have been more substance abuse related or mental health related, for us to do follow-up. So we're really, integral part of diverting from arrest charges and emergency department admissions. Obviously, we can't always divert from those three things, but the goal of the program is to do that, and it also saves money. The cost for arrest or for the emergency department is pretty high and costly, and so diverting from that is always the goal. We have a partnership with the Justice Resource Institute doing post-overdose follow-ups, and we also have services within advocates, recovery coaches that we do make referrals to. And speaking more directly about our service during COVID has been really full of surprises and challenges, which we have, I think, managed fairly well. But as mentioned, I started in April 2020, and it was literally the very beginning of COVID. So nobody really knew what we were going to do to provide service, and for the officers to be out in the community with the risk of COVID being present. And first and foremost, the overflow was apparent right off the bat because the outpatient services were limited, and the admission processes were limited for detoxes and hospital level of care. People were avoiding ERs for obvious reasons and things like that. So we definitely saw a pretty steep incline in what our need was in the community. And we saw a lot of trends of the correlation between unemployment, inability to access providers, and that may have also led to the use of substances, and because they weren't able to access their regular prescriptions. And we talked a little about pain management earlier. That has been something we see a lot, is folks that were already being treated for chronic conditions, and then things with substance abuse sort of spiral out of control with that. So for sure, we've been handling a lot of that. We see here in Marlboro a lot of folks that travel into town and are staying at there's a lot of hotels in the area. We track all of our overdoses and keep statistics on that. And there have been, unfortunately, an increase in those numbers in this past year and a half. So what we try to do is, when the police are called out for an overdose that requires them to go directly to the emergency department for treatment, we as the clinician, we're always putting in a referral for the recovery coach here at Advocates to reach out to the individual. We also have a crisis team on site, obviously at the ER. We're communicating with them. They are also within the advocate system, trying to really stack up all of the services we can offer. The other challenge has been that the recovery coaches and our partnership with JRI has been limited with doing face-to-face up until recently. So of course, that can be difficult for people who aren't fully on board with voluntary services yet. When you get a phone call, it's easier to push it aside, or it may feel like more work to be doing treatment through Zoom. People aren't always on board for that either. So as of recently, there's been more face-to-face services, which I think has been helpful. And with our post-overdose team that we're working with JRI, they will go out with a usually plainclothes officer to do follow-up with the individuals that we provide to them from our statistics of overdose. So, and if anyone has any questions as I'm going, please feel free to ask. I don't want to miss any opportunity to answer any of those. But I think that one of the other points that was mentioned was the lack of availability of beds. So we're seeing people often with dual diagnostic histories, and they may be actively detoxing at the time or need to before they can get into mental health treatment. And again, the ERs have been so challenged with volume and with the spread of COVID. And so, that has been really challenging, where like the regular routine might be missing, and the availability. And I'm sure that has impacted staffing within the facilities that would provide the inpatient treatment as well. So we are seeing people more routinely. We have some individuals that we see often and we know well, and it's a similar presentation each time. And again, we're trying to stack these services for them within the community. But I get the sense that it's a little bit more challenging for them to maintain those services with the barriers. And some of these folks don't necessarily have a smartphone to do these Zoom sessions, or even a phone number at all to be reached at. So again, follow-up has been very difficult and limited. So we are doing our best to continue to co-respond with the police, like I said, for even things that are not directly coming in as substance abuse or mental health, because a lot of times we get there and we find that is a large variable in the situation that brought us in to begin with. So we continue to do that and try to catch any folks in the community that might benefit from our services. But that is essentially what we're doing. And I think that, the points that were brought up about shortage of service are very much what we face as the clinicians, because we never stopped being face-to-face in this role, and working as a jail diversion clinician through advocates. We caught a lot of overflow from psychiatric emergency services, our crisis clinicians who were doing telehealth crisis assessments, and things were escalating. So then they would call those into the police department for us to go out on site. So our volume certainly increased with COVID. And with that, it has been frustrating because our typical line of action is different, because those services that we'd normally refer to are not as available right now. Does anybody have any questions about our role in this, or any of the barriers that we've had?
This is Nora. I wanted to ask, do you have any sense, or do you track of the interventions that you do? Because there's a connection with there's a call to the police department. Are any of those folks already hooked up with services? Are they hooked up with services through you? And is there a difference in the way you deal with them if they're already connected to services?
That's a great question. Thank you. So yes, so the caveat of being with advocates but working here at the police department really allows for this partnership of, when a well-being check comes in through dispatch, we're always looking immediately in our system for advocates to see if this person is already serviced, has any history of services, or has ever been seen by crisis, so we can see if there's any background. we are reaching out to providers that they either currently have or maybe like recently have had in the past on an emergency basis to try to reconnect or try to get a better sense of what is happening. A lot of times what we are seeing to that point is providers are calling in well-being checks because the client is not attending their remote services anymore. So that has been another thing where fortunately we're here and we can partner with the police and go out and do the well-being check alongside them. So then we're hopefully trying to reestablish or connect them back or figure out what is preventing them from being able to access the service. So yes, we definitely see a high volume of individuals who are already in our system for services or have been in the past. Any other questions? I can also speak to some of the trends we've seen with ages. So we capture that in our statistics as well. And I did, again, it was mentioned about adolescents. We've definitely, with students being home rather than at school, that was a very big shift. Eyes weren't on kids as much parents were working still and then trying to help their kids do their remote learning. Whereas when kids are in school, they're connected with our school resource officer, they have school adjustment counselors, they have eyes on them. And I think maybe their mental health and substance use may be better managed and maybe caught on to sooner when they're struggling. So we have seen periods that have increased pretty dramatically with us seeing youth versus adults. And I've seen that more towards like that last stretch of remote learning for kids. And it was coming from them not engaging in remote learning and people being concerned, and some behavioral things were spiking. But so we definitely saw an increase in that. And we saw an increase in people, adults more in like that middle age range. And a lot of it seemed to be from my experience, the pressures of, again, financial pressures, the loss of daytime structure. That's a big thing for people who are maintaining sobriety or managing their mental health, having predictability and a routine. And that has been taken from everybody. So we did see an increase in those things as well.
I don't want to monopolize, but I always have a lot of questions.
Please ask away.
Yeah, this might be a question for you and other providers. So I do a lot of reading in this space, and there have been all this talk about changes in accessibility to medication-assisted treatment during COVID, changes in harm reduction perspectives during COVID. It sounds to me that all of this is fine, except we don't have the providers. Are you seeing, especially with the expanded access to longer term MAT, has that been something that has been helpful? Has that been something that folks didn't know about, and maybe through an intervention they could find out?
Mm-hmm. So in regards to that, so one of the benefits of working with JRI has been that they're doing the harm reduction, providing safe use and pamphlets and things like that, where our recovery coaches are more focused on maintaining recovery and accessing and navigating that system. And I think that has, been a really big part of this, trying to be mindful of the risks involved with individuals who are using. Like I said, there's been a lot of increase in overdoses at our hotels, and usually people are trying to just find a place to stay. They may otherwise be homeless, limiting their ability for follow-up because they're hard to track. So it has been really useful to have people out in the community that are now going out and doing face-to-face again, and doing the harm reduction education and work, and providing things that I can't provide and the officers can't provide. So that's been extremely helpful in trying to improve our volume of overdoses and fatalities.
Thanks. Other questions, comments, input?
Carrie, thank you.
Thank you, guys. If you have any other questions, please let me know.
Any comments, thoughts, updates, events that people want to put out there for us? Oh, Kara, people are asking for your number.
Oh yeah, I can put that right in the
The
chat,
chat.
if that's okay. I'll put contact information for, yeah, no problem.
Anybody
Marion,
else?
yeah, I just wanted to say one quick, Malden Cares program. You were absolutely straight on right, relevant to the ability of providing water at the beginning, because we're out there on a daily basis at the MBTA station in the center of Malden. We're Monday through Friday, but we are increasing now to Saturday to Sunday. But we literally almost give out 224 case packs of water while we're out there. And also we are now able to go out to like the OYO and different places. And without that, really, we think that there is a need still. We're all zoomed out, and I'm grateful to be back out in the field again. And it's you know, so, and thank you so much, Marion, again, for your support for the Bridge to Hope. The seniors and those that are taking care of the children, the grandparents and their own family members, that behind the door syndrome, you gave them a great deal of comfort, because Narcan is really hard to get right now. It's and the co-pays and all of that, and then some of the different seniors, they got all upset when their PCP contacted them and said, you know, do we have to have a talk? You know, because they got notified that they were using, you know, going down to the local pharmacy and getting Narcan. So now they're like, I don't want to ever get Narcan again at the pharmacy. So it's, you know, things that we don't expect to be happening.
Well, thank you. And we've just made another huge purchase. So to the extent that people need it for it to be leaving behind or giving out or whatever, we are happy to provide that. And to the grandparents, I'm going to be doing again a grandparents education piece on October 12th from 7 to 8:30 at night. For those people raising grandparents, things to be concerned about, things to be watching for, some internet safety, all of those pieces. So we'll get that out to people.
Perfect.
It's obviously Zoom, so you can sit at home and watch.
Yeah. Thank you.
Of course. Anybody else? Anything going on that people want to tell us about? No? All right. Just as an update, our next meeting will be September 22nd and then October 28th. So you can add those dates now. Nora will obviously get more information out as we get closer. Again, thank you all so much for being here. Stay safe, be safe today. It's looking like a pretty scary day to be out on the road today. So be safe. Thank you all. Take care. Thank you, Nora.
Thank you.
Thank you.